Hello, this is Eric Strong once again, and this is the 13th lecture in this course on understanding ABGs. Today's topic is a synthesis of the traditional approach to acid-base analysis. In other words, I will summarize the first 12 lectures before demonstrating how that knowledge can be used to diagnose some complex acid-base disorders. The specific learning objectives are first, to have an understanding of how the various pieces of the traditional approach to acid-base analysis fit together into a cohesive whole, and second, to be able to use the traditional approach to identify acid-base disorders and be able to create a differential diagnosis based upon a patient's history, exam, and additional laboratory data. In the first two lectures, the arterial blood gas was introduced, as well as the 5 major physiologic parameters that the ABG reports: the pH, the PaCO2, the PaO2, the bicarbonate concentration, and the oxygen saturation. The acid-base balance of a person can be deduced through the relationship between pH, PCO2, and bicarb. This relationship is specifically defined by the Henderson-Hasselbalch equation shown here. In Lecture 3, the terms acidemia and alkalemia were introduced. Acidemia is a state in which the serum pH is less than 7.35. Alkalemia is a state in which the serum pH is greater than 7.45. An acidosis or alkalosis is any process which tends to drive the pH towards acidemia or alkalemia, respectively. Also in Lecture 3, the distinction between respiratory and metabolic disorders was introduced. Respiratory disorders are those pathologic processes which disrupt acid-base balance due to their effects on the lungs. They can be either a respiratory acidosis, where the PCO2 is too high, as seen with hypoventilation, or they can be a respiratory alkalosis, where the PCO2 is too low, as seen with hyperventilation. In contrast to this, metabolic disorders are those processes which disrupt acid-base balance due to their effects on anything other than the lungs, such as the kidneys, GI tract, or cellular respiration. With a metabolic acidosis, bicarb is too low, while with a metabolic alkalosis, bicarb is too high. Lecture 4 discussed the process of compensation, in which the body attempts to neutralize derangements of acid-base balance. In a metabolic acidosis, for example, in which low bicarb leads to low pH, the mechanism of compensation is increased ventilation, which leads to lower PCO2 driving pH back towards normal. In a metabolic alkalosis, in which high bicarb leads to high pH, the body compensates by decreasing ventilation, which leads to higher PCO2 and lower pH. In a respiratory acidosis, the kidneys compensate by increasing reabsorption of bicarb and increasing excretion of hydrogen ion. Finally, in respiratory alkalosis, the kidneys compensate by decreasing bicarb reabsorption and decreasing hydrogen ion excretion. As mentioned previously, compensation for a metabolic alkalosis is the least robust of these mechanisms because hypoventilation will lead to hypoxemia, which in itself is a strong stimulus to increase ventilation back to normal. To determine if the compensation for a particular disorder is appropriate, there are a collection of empirically derived formulae. The formulae provide predictions as to what either the PCO2 or the bicarb should be given the other if compensation is appropriate. Each disorder is paired with either one or two formula. The metabolic disorders are paired with only one formula for respiratory compensation since it occurs very quickly, while respiratory disorders are paired with separate formulas for metabolic compensation depending upon whether the respiratory disorder is acute or chronic. The timing of the transition from an acute respiratory process to a chronic one varies greatly between sources, but is generally cited as between 12 hours and 5 days. If compensation is not appropriate using this analysis, it is strongly suggestive of an additional acid-base disorder that is interfering with the compensation mechanism. It is important to realize that physiologic compensation will never bring the pH all the way back to normal. Lecture 5 introduced the anion gap. a mathematical construct that is meant as an indirect surrogate for measuring the accumulation of difficult to measure anions in the serum, which lead to a subtype of metabolic acidosis, appropriately called an elevated anion gap acidosis. The anion gap is calculated as the serum sodium minus the sum of chloride and bicarb. Because negatively charged albumin is a major contributor to the anion pool, the anion gap should be adjusted in states of significant hypoalbuminemia using this empirically derived equation. The normal range of the adjusted anion gap is approximately 8 to 12 milliequivalents per liter, though it varies slightly from lab to lab. There are a number of conditions that can cause abnormal anion gaps in the absence of a metabolic acidosis, both those that cause a high anion gap and those that cause a low one. Of these, as implied before, hypoalbuminemia is the most important. Lecture 6 focused on the delta ratio, which is the ratio between the change in anion gap from normal and the change in bicarb from normal. It should be calculated whenever the anion gap is elevated. In general, the delta ratio is the only means to identify multiple simultaneous metabolic disorders. At first glance, it may seem that the delta ratio should be 1 in an uncomplicated elevated gap metabolic acidosis. That is, for every 1 milliequivalent per liter of unmeasured anion picked up by the anion gap, 1 milliequivalent per liter of bicarb should be buffered. However, since there are other buffers besides bicarb, the delta ratio is often greater than 1. Here is a table of some empirically discovered expected values of the delta ratio for specific pathologic processes. And here is a table to help interpret the delta ratio. If the measured ratio is lower than the expected range, it means that bicarb has dropped much more than the anion gap has increased. This would require a simultaneous elevated gap acidosis and a normal gap acidosis. If the delta ratio is within the expected range, there is only an elevated gap acidosis present. If the ratio is higher than expected, then there must be both an elevated gap acidosis and a metabolic alkalosis. It's important to realize that the delta ratio is only used for analyzing metabolic disorders and does not preclude the possibility of a concurrent respiratory disorder. And if things weren't complicated enough, Lecture 7 introduced the possibility of multiple acid-base disorders that perfectly balance to result in a normal pH. There is neither a simple nor memorable algorithm to handle this situation. While some people might be able to successfully deduce which disorders were present given a specific ABG, this table gives everyone a foolproof means to do this. At this point, the lecture switched to discussing the 5 major acid-base differential diagnoses. First was elevated anion gap metabolic acidosis, which focused on measuring lactate and ketones first, renal function second, and then the osmolar gap last. Next was normal anion gap acidosis. The first step here was to stop any infusion of normal saline, then check renal function, and if this was fine, to assess serum potassium, urine pH, and the urine anion gap. The approach to a metabolic alkalosis starts with assessment of intravascular volume status. If low, the history usually will provide the correct diagnosis. If volume is normal or high, the next step is to assess blood pressure and serum potassium, which will help distinguish between mineralocorticoid excess, hypokalemia, or exogenous alkali intake. The etiologies of a respiratory acidosis were too numerous and varied for a simple algorithm, though obstructive lung disease, drug toxicity, and the obesity hypoventilation syndrome are all much more common than the others and should be investigated first. Finally, in Lecture 12, I did not provide a flowchart but simply listed etiologies as being either common or uncommon, with all but hypoxemia and pulmonary embolism being quite rare. However, here is a simple flowchart one could use instead. So now, how does one incorporate all of this knowledge into a single, coherent algorithm for assessing a patient's acid-base status? Here it is, my master algorithm for conquering acid-base. Step 1. Check pH. This will determine if an acidemia or alkalemia is present. If the pH happens to be normal, but either the PCO2 and or bicarb is not, check the anion gap and refer to the table on mixed disorders with normal pH. Step 2. As long as pH is abnormal, check the PCO2. If the PCO2 is deranged in the same direction as the pH, the initially identified disorder is metabolic. If it is deranged in the opposite direction, the disorder is respiratory. Step 3. Check compensation. If compensation is not appropriate, another disorder is present. If compensation is appropriate, there may still be more disorders present depending upon the anion gap and delta ratio. Step 4. Always check the anion gap, remembering to correct for low albumin. If the anion gap is elevated, there is likely an elevated anion gap metabolic acidosis. Step 5. If the anion gap is elevated, always check the delta ratio. If the delta ratio is lower than expected, there is also a normal anion gap metabolic acidosis. If it is higher than expected, there is also a metabolic alkalosis. Step 6. Using the flowcharts, acquire additional relevant diagnostic data for each identified disorder and generate a differential diagnosis, keeping in mind the law of parsimony. For those of you not familiar with the law of parsimony, it can be paraphrased as the simplest explanation is the one most likely to be correct. When it is applied to generating differential diagnoses, it suggests that the presence of multiple simultaneous acid-base disorders is more likely the result of one common pathophysiologic disease process. This doesn't always hold true, particularly in older patients with many medical problems who may have chronic acid-base disturbances that precede an acute illness. However, it's always an important principle to keep in mind. At this point, I'm going to go through 4 examples of how to apply the master algorithm to complicated patient cases. I would encourage you to intermittently pause the lecture as I go along in order to give yourself the chance to arrive at each diagnosis on your own. Example 1. A 75-year-old woman is sent to the ER from her nursing home with fever and dyspnea. Her vitals on arrival are temperature 102.2, heart rate 122, blood pressure 95/40, respiratory rate 35, and O2 saturation 84% on 6 liters of oxygen delivered via a face mask. The remainder of her exam is most notable for crackles and decreased breath sounds at the right lung base. Here is her pH, PCO2, and bicarb, along with a basic chemistry panel and serum albumin. Step 1. Check the pH. We obviously see that she is alkalemic. Step 2. Check the PCO2. Since the PCO2 is deranged in the opposite direction as the pH, that is, the PCO2 is lower than normal and the pH is higher than normal, the initial process to be identified will be respiratory, and thus a respiratory alkalosis. Step 3. Evaluate compensation. The history suggests that this is an acute process, and the specific prediction rule for an acute respiratory alkalosis is that the bicarb should be decreased by 2 for every 10 that the PCO2 is less than 40. Since the PCO2 is 15 less than 40, we would expect the bicarb to be 3 less than normal. That is, we expect the bicarb to be 21. 17 is not really close enough to 21 to call it good, and therefore compensation is not appropriate. Since the bicarb is lower than expected for normal compensation, an additional metabolic acidosis must be present to further drive it down. Step 4. Calculate the anion gap. This is sodium minus the sum of chloride and bicarb, which here is 21. The anion gap adjusted for her modestly low albumin is 24. Thus, she has an elevated gap metabolic acidosis. Step 5. If the anion gap is elevated, calculate the delta ratio. The delta ratio is the change in anion gap from normal divided by the change in bicarb from normal. So in other words, 24 minus 12 divided by 24 minus 17. This will be 12 divided by 7 which equals 1.7. 1.7 falls within the expected range for all etiologies of an elevated gap metabolic acidosis, with the exception of DKA, which just can't be with her completely normal glucose. Therefore, we conclude that the elevated anion gap metabolic acidosis is the single metabolic process present. So to summarize at this point, we have a respiratory alkalosis that's probably acute based on history, and an elevated anion gap metabolic acidosis. Until this point, steps 1 through 5 have all been introduced in prior lectures, so this should have felt a little like review. But step 6 is essentially new. That is, how do we go about generating a differential diagnosis? Since her respiratory alkalosis is both the first disorder identified and has the shortest list of possible etiologies, let's start there and look at the flowchart for the approach to a respiratory alkalosis. The starting point is an assessment of oxygenation. In this case, it's low, so the cause of her alkalosis is essentially hypoxemia. And at this point, we would then worry about the differential diagnosis of hypoxemia. This actually won't be reviewed until lecture 18. However, some basic knowledge of lung pathophysiology will probably allow you to think of a couple of possible explanations off the top of your head. For example, pneumonia, pulmonary embolism, pleural effusion, and pulmonary edema all might seem possible at this point. So what diagnostic data should you acquire to narrow this down a little? How about a chest x-ray? In this case, a chest x-ray demonstrates a right lower lobe consolidation consistent with the abnormal auscultatory findings on exam. Given the overall scenario, a bacterial pneumonia seems likely. Next, let's consider the differential diagnosis of the elevated gap metabolic acidosis. Looking at the flowchart, we start here. The low bicarb, out of proportion to the expected compensation, confirmed the presence of an acidosis. Therefore, moving to the next step, check lactate and ketones. Going back to the patient's data, lactate is elevated at 5.2 and ketones are negative. With an elevated lactate, we next look for hypoperfusion. In the patient's case, hypoperfusion appears to be systemic, so this patient likely has emerging shock. Therefore, her final diagnosis can be given as severe sepsis or possibly septic shock, secondary to a right lower lobe pneumonia complicated by lactic acidosis. Example 2. A 32-year-old woman with schizophrenia is found unconscious on the floor of her garage. Vitals in the ER are temperature 99.2, heart rate 120, blood pressure 104/56, respiratory rate 6, and oxygen saturation 88% on room air. Here is her ABG, chemistry panel, and albumin. Step 1. Check pH. Obviously, an acidemia is present. Step 2. Check the PCO2. There is a respiratory acidosis. Step 3. Evaluate compensation. This sounds like an acute process from the brief vignette. For an acute respiratory acidosis, the bicarb should be increased by 1 for every 10 that the PCO2 is greater than 40. But the bicarb here is actually decreased. So therefore, not only is compensation not appropriate, there must be an additional metabolic acidosis. Step 4. The anion gap. 132 minus the sum of 25 and 12 is 25. Adjusted for albumin, it becomes 30. So there is an elevated gap metabolic acidosis. Step 5. The delta ratio, which is delta anion gap divided by delta bicarb. 18 divided by 12 is 1.5. As with the last example, while we don't yet know the etiology of the elevated gap acidosis, a delta ratio of 1.5 is in the expected range for everything but DKA, which this is obviously not. So therefore, there is not an additional metabolic process present. Now, step 6, generate a differential diagnosis. Since the differential diagnosis of an elevated anion gap acidosis is smaller and somewhat more contained, so to speak, than that of a respiratory acidosis, let's start there. As with the last example, We have confirmed the presence of an elevated anion gap, so the next step is to check lactate and ketones. Going back to the patient, a lactate is minimally elevated at 2.1 and ketones are negative. Given the severity of the acidosis, it seems unlikely that the near normal lactate is responsible. Next step is to check renal function. Going back to the patient again, we can see that her creatinine is 1.6. While this is not normal for an average-sized 32-year-old woman, it's sort of near normal and certainly not equivalent of a GFR less than 40. Plus, her adjusted anion gap is too high for this to be due to renal failure. So let's go back to the flowchart and keep going. The next step is to check the osmolar gap. Remember that the osmolar gap is the difference between the measured serum osmolarity and the calculated serum osmolarity. Serum osmolarity here is measured at 310 milliosmoles per liter, which is elevated. Calculated serum osmolarity, however, is equal to 2 times the sodium plus the BUN divided by 2.8 plus the glucose divided by 18. Plugging in the values for this patient, we get a normal 277 milliosmoles per liter. This gives us a gap of 33. Back to the flowchart, and we see that an osmolar gap greater than 20 is consistent with the ingestion of a toxic alcohol, either methanol or ethylene glycol. Unfortunately, specific testing for these is not typically available in a clinically useful time frame, but the available data here is consistent enough for a presumptive diagnosis. So this answers the question of the elevated gap metabolic acidosis, but what about our respiratory acidosis? First, if the levels are great enough, either methanol or ethylene glycol could potentially lead to respiratory depression, though it's not a particularly common manifestation. Since toxic ingestions frequently consist of more than one substance, additional screening is indicated. Here, ethanol is non-detectable, but a urine tox screen is positive for opiates. Therefore, our final diagnosis is the presumed ingestion of a toxic alcohol in combination with a narcotic. At this time, one could not definitively rule out co-ingestion with additional respiratory depressants, since numerous other drugs cannot easily be tested for, such as antihistamines, antipsychotics, antidepressants, and muscle relaxants. Example 3. A 56-year-old morbidly obese man with diabetes and hypertension presents to pulmonary clinic after referral from his primary medical doctor for asymptomatic hypoxemia. He has no history of smoking. His vital signs are heart rate 85, blood pressure 152/86, respiratory rate 16, O2 saturation 90% on room air. His BMI or body mass index is very elevated at 45. It is difficult to auscultate his heart and lung sounds, presumably secondary to his body habitus. And here is his ABG, chemistry panel, and albumin. Step 1, he has an acidemia. Step 2, it's due to a respiratory acidosis. Step 3, since he's being seen in clinic for a routine referral, whatever processes are going on are presumably chronic. The compensation formula for a chronic respiratory acidosis asks if the bicarb is increased by 4 for every 10 that the PCO2 is above 40. In this case, no. The bicarb is lower than expected, and in fact it's unchanged from normal. The explanation must be a concurrent metabolic acidosis. Step 4. Calculate the anion gap, which is 8. Corrected for albumin, this becomes 9. So the patient has a normal anion gap metabolic acidosis. Step 5. Since the anion gap is not elevated, we actually skip this. Step 6. The differential diagnosis. There's no great way to decide which of the two acid-base disorders to start with. Since he was referred to pulmonary clinic for a respiratory problem, I'll start with a respiratory acidosis. As already mentioned, the complete list of possible etiologies for this is very long, but most respiratory acidoses are the consequence of one of 3 leading problems: obstructive lung disease, that is COPD or severe asthma, obesity hypoventilation syndrome, and drugs. Lack of a smoking history makes COPD very unlikely, as would be new onset asthma in a 52-year-old. There is no suggestion of drug intoxication, plus this process is chronic. Although his morbid obesity is very consistent with obesity hypoventilation syndrome, this is technically a diagnosis of exclusion, so we must somehow rule out everything else, such as a brainstem lesion, neuromuscular disease, interstitial lung disease, etc. There isn't one obvious definitive way to do that, but if we see that his neural exam is completely normal, and his chest x-ray is also completely normal, it will go a long way to confirming the diagnosis of obesity hypoventilation syndrome. Now, what about that normal anion gap acidosis? We haven't seen the flowchart for that in these examples yet, so here it is. The first thing we should do is to make sure any infusions of normal saline are either stopped or switched to lactated ringers, which is obviously not relevant here, so we will skip down a bit. We will then ask whether creatinine clearance is less than 40. To remind you, his creatinine was 1.7. While this isn't normal renal function, his creatinine clearance won't be below 40, so we move to the next step, which is to assess serum potassium, urine pH, and the urine anion gap. Returning to the patient, we see that the potassium is a little high at 5.8. We check the urine pH and see it is 5.0. Next is the urine anion gap, which is calculated as urine sodium plus urine potassium minus urine chloride. So let's check those and plug them into the equation. 60 plus 10 minus 15 is 35 milliequivalents per liter, which is above the cutoff value of 20. Therefore, we would label this urine anion gap as elevated. So what should we do with this information? Going back to the flowchart, we see an elevated potassium, low urine pH, and high urine anion gap is all consistent with type 4 renal tubular acidosis, or RTA. So our final diagnosis here is a chronic respiratory acidosis from obesity hypoventilation syndrome combined with a coincidental type 4 RTA. While I won't get into the specifics of the differential diagnosis of the RTA itself, leading contenders based solely on the limited information available for this patient would be diabetic nephropathy and the side effects of an ACE inhibitor, which as an hypertensive diabetic he is probably on. You might have noticed that this conclusion violates the law of parsimony, as his mixed acid-base situation is the consequence of two completely independent processes. But he is also a relatively old and chronically ill person, the type of patient in whom the law of parsimony is most often violated. Here is the last example. A 60-year-old alcoholic is found down in an alley soiled with vomit. He is comatose in the ER with vitals temperature 102.5 degrees Fahrenheit, heart rate 130, blood pressure 74/36, respiratory rate 8, and O2 saturation 80% on room air. Here are his labs. Step 1, his pH is surprisingly normal, though his PCO2 and bicarb clearly are not. So where do we go from here? With a normal pH, step 2 actually jumps ahead to the anion gap. In this case, it's 15 milliequivalents per liter, which adjusts to 21. So the patient probably has, at the very least, an elevated anion gap metabolic acidosis, and given the fact his pH is normal, he must have an alkalosis as well of some kind in order to balance it out. Step 3 in this case will be to check the table for mixed disorders with normal pH. We see that the patient's PCO2, bicarb, and anion gap are all elevated. Therefore, he falls into this category: a combined respiratory acidosis, a metabolic alkalosis, and an elevated anion gap metabolic acidosis. I'm going to condense that result like this in order to give us a little bit more room on the screen. Now, our final step will be to generate a differential diagnosis. You can reasonably start with any of the three disorders. I'll pick the respiratory acidosis. As before, we should first look at the possibilities of COPD, asthma, OHS, and drugs. Given the history here, drugs seems like the most likely of these. So we check an ethanol level and see it is extraordinarily elevated at 390 milligrams per deciliter, which is 5 times the legal driving limit here in California. Since alcohol and drugs often go together, we should also check a urine tox screen, which in this case is negative. So the respiratory acidosis is well explained. Next, let's tackle the metabolic alkalosis. Here's our metabolic alkalosis flowchart. The first step is to assess volume status. Given this patient's tachycardia and severe hypotension, even without being given more details about his physical exam, it seems highly likely that he is dehydrated. Therefore, we next take a look at his history and see if he's at risk for any of these. By history, it seems that he may have both a contraction alkalosis from dehydration, as well as hydrogen ion loss through vomiting of gastric acid. So the metabolic alkalosis seems well explained. Finally is the elevated anion gap metabolic acidosis. We've been through this before. His high bicarb raises the question as to whether he has a non-acidosis cause of an elevated anion gap. In addition, a metabolic alkalosis in and of itself can raise the anion gap by causing a shift in the equilibrium between charged and uncharged species of non-bicarbonate buffers. However, given the clinical scenario, it seems prudent to push ahead through the full flow chart and see what shakes out. So we'll check lactate and ketones. Lactate is moderately elevated at 4.3, and ketones are positive. Returning to the flowchart, we'll go down both paths simultaneously. For the elevated lactate, his severe hypotension is consistent with systemic hypoperfusion from shock, and his alcohol history is consistent with alcoholic ketoacidosis. Returning back to the patient again, before we give a final diagnosis, we need to ask, why does he have a lactic acidosis? In addition to a thorough physical exam and blood and urine cultures, a chest X-ray is also indicated. In this case, it revealed a right middle lobe consolidation, a common location for aspiration, as might be seen in a passed-out alcoholic. Also, for a number of reasons discussed in the full-length version of Lecture 8, alcoholics are already much more prone to getting lactic acidosis in general than non-alcoholics. Therefore, our overall summary diagnosis would be respiratory depression from acute alcohol intoxication, combined with a metabolic alkalosis from vomiting and dehydration, and a lactic acidosis secondary to septic shock, possibly due to aspiration pneumonia and an alcoholic ketoacidosis. That completes this review and synthesis of the first 12 lectures in this course on ABG interpretation. I hope you found this to be a helpful summary of everything presented so far. The next lecture will discuss several common pitfalls in acid-base analysis that have not already been addressed elsewhere.